and also the number of A's was a lot higher. The number of so a lot, for the last couple of years, the pass rates in the GI block was one of the best in year 3. I think it was the best last year, and the number of A's was also higher than most of the other blocks, including some of the shorter blocks. So, I mean, if you add everything together, I don't think you need to be that apprehensive. I'm telling you this because obviously I'm receiving a lot of jittery nerves in my office. I don't think you need to do that. I think you need to quote unquote enjoy the block if you can. It's a lot of clinical. You're going to be facing all this clinical in year 4. So in one way, it's going to be preparing you for year 4. And in another, for those of you who are taking the, any kind of standard examination, it will help as well. For your information on the NBME for the past 5 years, the two best blocks actually that our candidates score on the NBME were the GI and the MSI, believe it or not. Both of them, I was actually I was running the GI for the past 6 years. This year it is Dr. Wael, who is the block director.
Share the slide, please.
Yes. So all I'm saying to you is don't listen to anybody from 2 years or 3 years ago. I think you need to see for yourself. Hopefully you're able to to catch up to the lectures. I think this is the most important part of what you do in this block. Try to catch up to the lecture, especially the clinical lectures. Thank you very much. All right, so we are going to be talking about the stomach. There used to be some slides about anatomy and physiology. I felt that probably it will be an overkill to go over them again, especially that it was covered in physiology and it was covered also in immunology. Okay, so but a couple of words actually to remember. One of the most important things to remember, believe it or not, is this small fact, which is going to be that actually, the cardia, which is the first part, where the bolus of food is going to enter the stomach coming from the esophagus, and the last part, which is going to be the antrum and into actually into the pylorus and then into the duodenum. These two areas are going to be rich in cells that are going to richly secrete mucus. I think that's very logic because you want to ease things in and ease things out as they leave the stomach. This is one. 2, when it comes to the fundus and the body of the stomach, they are rich in cells that are producing the HCl, the acid, and that's also pretty logic. If you remember that, and then if you remember where is the actual inflammation happening at the level of the stomach, as you will see in the next few slides, you will actually be able to gather, and you will be able to collect a lot of information that will never actually be forgotten. Okay, so starting with the inflammation of the stomach, we are going to go through them one by one. The first one is going to be a pretty superficial kind of inflammation. The thing that usually follows, for example, ingestion of NSAID, non-steroidal anti-inflammatory drugs, something that is going to be associated, for example, with alcohol ingestion, or with an ARDS, someone who actually go through trauma or through blood loss, and they are going to be presenting with acute gastritis. That type of acute gastritis is usually transient and self-limited. So the minute that you stop the NSAIDs, the minute that you stop the alcohol ingestion, you will see that the mucosa will start to actually recover itself, re-epithelialize itself. And as a result of that, you will see that there is complete recovery from those kind of instances. I take back what I said about ARDS. ARDS is usually going to put the patient into other actually forms of itis, as we will see. So, the superficial ones are going to be the ones that you see with acute superficial gastritis. So example of that, the NSAIDs I mentioned to you, alcohol abuse, cigarette smoking, and we will see that each one of them have its own way of doing things. So for example, for the NSAIDs, it's going to actually suppress the cyclooxygenase. And as a result of that, you will see that there is going to be a problem actually with the vascular supply of the gastric wall, the gastric mucosa. This is one. Two, there will be actually also problem in bicarbonate secretion, which is happening from the gastric foveolar cells. So as a result of that, when you actually are going to diminish the defense mechanisms of the stomach, the end result is going to be actually that the forces of damage and injury are going to overwhelm the forces of defense, the forces of protection of the gastric mucosa, and damage will happen. Each one of them, as I mentioned to you, will do it in its own way. Alcohol has a direct toxic effect on cells. This is known pretty much everywhere you go, the liver, here, the GI. Cigarette smoking, in terms actually of its deleterious effect, direct deleterious effects on the gastric mucosa. This is one. Two, on the blood supply and of the blood supply of the gastric mucosa. Shock and uremia. So in a way, shock, yes, again, we're taking out actually the profuse blood supply to the gastric wall, and that is going to, to result in the same kind of presentation. Mechanical trauma nasogastric tube. This is meant to be actually put in for a short period of time. If you make it indwelling, if you forget about it and leave it there, that is going to result in damage to the gastric mucosa, acute damage. If you leave it on for a longer period of time, it will result even in further damage to the gastric wall, may even perforate actually the gastric wall. One of the reasons why is that the case is that the mucus layer and the layer on top of the mucus layer, that is actually that is going to harbor the bicarbonate, are meant to keep actually the tube or any kind of food actually from direct contact with the gastric mucosa. There should be no direct contact with the gastric mucosa, because if there is direct contact, then damage may happen, especially with pieces of food that are large, pieces of food that are still harbor some like the projections in them. So there will be no kind of contact. If that actually is taken out, if the barrier is taken out, then damage is going to happen. Here's actually just a little review about what you find in defensive forces, and how does damage happen. So defensive forces, you have this mucus layer, that is going to be on top of the epithelium. This mucus layer is very important, because again, it keeps the food from, or any kind of objects really, including the nasogastric tube, from direct contact with the epithelium. On top of this mucus layer, there is another layer of unstirred fluids that harbor, the bicarbonate that is secreted by the gastric foveolar cells, the same cells that produce the mucus. And again, because of the bicarbonate, you will see that this is going to neutralize the effects of the acid on the gastric wall. Now, in addition to this, and probably the most important, is going to be the very, rich, the very robust blood supply to the gastric wall. Why is that the case? Because if there is any kind of break in the defense, of the mucus and on the layer on top of it, and as a result of that, some of the fluids actually seep through the gastric mucosal wall. The blood supply, the blood vessels are going to take up this acid, and they are going to reroute it away from the gastric wall, so as not to cause any kind of injury or damage to the gastric wall. So in the stomach, you don't really need much to cause injury. The only thing you need is for this acid to find its way into the gastric mucosa. So any kind of injury right here is going to result in this damage. So with, for example, the NSAIDs, we have seen that there is going to be, as a result of the suppression of cyclooxygenase, the mucus is gone. This is one. Two, also the blood supply is going to become deleterious. And let's say you talk about H. pylori infection, we will see that there is a couple of ways where the H. pylori infection are going to cause damage as we will see then in a few slides, but I can just mention to you very briefly here. You will see that the H. pylori is going to result in hyperacidity, and we'll talk why. And then it's going to cause also, problems, actually, some thrombotic events in the rich blood supply of the gastric wall. And as a result of that, it will allow for the acid to seep through and to cause damage to the gastric mucosa. Now, this is, as you can see here, you can see that there is no really, no kind of like permanent damage. You look at the blood vessels, if you can trust actually what they write about this, and you will see that the blood vessels are still thin. So they have not become thickened, as you will see in an ongoing chronic kind of condition. This is one. Two, you look at the lamina propria and you will not see any kind of fibrosis. Once this process becomes long-term, once it becomes instituted and on a long-term basis, you will start to see that the blood vessels are going to become thickened. This is number one. Number two, you will start to see that there is going to be some fibrosis actually effects that are present in the lamina propria. Okay, so now, as you can see here, the epithelium is still very much intact. Maybe just the most tip of the epithelium have been affected with this process. So this is why you call it superficial. Acute erosive superficial. If there is any blood that is associated with it, you may call it acute erosive hemorrhagic gastritis. Some of the things that may actually be complicating this condition is if it involves a blood vessel, a relatively large blood vessel, because of the fact that you have so many of these blood vessels in the gastric mucosa, all to the upper layer of the lamina propria. So if this process somehow actually affected these blood vessels, it's going to be accompanied by hemoptysis. Okay, so the patient is going to actually be producing blood, is going to be spitting blood as a result of the involvement of one blood vessel or another in the lamina propria. Now, if the process becomes actually instituted and becomes long-term, and there is an ongoing damage, for example, that is something that you will not see with any one of those unless you are continuing actually doing it. For example, ingesting NSAIDs, ingesting aspirin, with large amounts over. You cannot really do it over a long period because of the complication of this. You will have so much blood coming out that will make you stop doing it. So something with, for example, H. pylori infection, this is something that is going to be long-term. So the symptoms are not going to be as stark, and as a result of that, the damage will be ongoing. So much so that there will be a lot of loss of mucosa. The mucosa is going to dig deep. The ulcer is going to dig deep into the mucosal wall. And as you can see here, it's far larger than anything that get lost here. Okay, so there is a larger kind of defect in the mucosal wall, and that is going to be counted as an ulcer, a true ulcer. With the true ulcer, you will start to see that one of the features of a benign ulcer is going to be, the fact that the pit of the ulcer is clean. So there is some necrotic debris, but then it will be cleaned up. What is going to clean up actually the necrotic debris in the base of the ulcer? Acid. Acid will take care of is going to burn everything that is there, really. Okay. Have you seen ever a damage by acid or bile? Ever? Any one of you? It dissolves it completely, actually. Exactly. So this is why you will see with a benign ulcer that it's going to simply liquefy that, and it will be a clean pit, so to speak. Now, what happens if this is actually what you call an ulcerating carcinoma? With ulcerating carcinoma, a lot of instances you will see that there is achlorohydria, meaning you have less actually acid that is being produced. And as a result of that, the pit of the ulcerating tumor is going to be dirty. This is what you call dirty pit, is what you find in ulcerating cancer, okay, or ulcerating tumor. Now, coming back to an ulcer, to a benign ulcer that results actually from the H. pylori, you will see that there is also going to be, in the first phase at least, acute inflammatory cells that may go all the way up actually into the epithelium and will go into the pits of the gastric pits, resulting in what's known as a pit abscess. And you will start to see also, the starting formation of granulation tissue. The granulation tissue here is happening because of the attempt of recovery, but because of the ongoing basis, recovery will never be complete. And you can see that this is not going to actually shorten, or it's going to actually make this ulcer smaller by any chance. At the same time, parts of this, process is going to realize that this is actually going to be long term, and will start to, start to heal. And the healing in this case is going to be by fibrosis. So you will see in the wall of the ulcer, beneath the ulcer, pit, is what you are going to find actually starting the formation of fibrotic tissue, as you can see here. So features that you see on an ongoing basis, ongoing damage to the mucosal wall. All right, so acute gastritis, again, the presentation may be with asymptomatic painless bleeding, small bleedings, a small amount of bleeding. Sometimes actually it may be massive and fatal. Example of what I mentioned to you, if it happened that it involved one of the blood vessels that are present in the lamina propria. There is variable epigastric pain, nausea, and vomiting. It is one of the major causes of hematemesis. I'm sorry, hematemesis. I said hemoptysis. I apologize. Hematemesis. Okay. Now, when you look at this, you're going to be seeing actually, what looks like small pits of dark discoloration of the mucosal wall. And if you take each one of those, it's going to be associated with bleeding. So there's blood that has been formed actually there. In addition to this, you see inflammation and very slight loss of tissue. There may be actually loss of a mucosal, the mucus layer, but the epithelium itself is still intact. The epithelium itself is still intact, but the mucus has been lost. And in addition to this, you may start to see a little bit of bleeding nearby. So if you look at this, if you take a section of any of these lesions, and usually you don't do that for acute gastritis, but this is a patient who died as a result of something else. And during autopsy, they found out that this is actually present in the stomach of this patient. If you take a section of this, you will see that there are sheets of neutrophils that are present above the basement membrane. So you will see it in the superficial epithelium above the basement membrane. You can see that sheets of neutrophils. Now, even though there are sheets of neutrophil, but you will not see it actually coming in the gastric pits. This is something that is going to be actually limited to more severe cases of post-acute inflammation and then chronic inflammation. This is something that we're going to be finding with the H. pylori infection, as you will see in the next slides. All right, so now acute peptic ulceration. So we have moved from the acute superficial erosive, maybe hemorrhagic gastritis to acute peptic ulceration, or what is known as stress ulcers. And this is something that is found usually in any patients who go through a very traumatic kind of event. For example, someone with severe burns, severe trauma, intracranial injury. We will see how that happens actually. As you can see, NSAID is always there. But again, if you want to think about it, NSAID in this case have been actually taken in larger amounts over a longer period of time. So it's a matter of, how much is the patient exposed to the damaging, factors, of the gastric mucosa. So what you're going to be finding actually, let's say, someone with severe burns or severe trauma, those conditions are going to result in a lot of destruction of tissue. And this tissue is going to be actually, this destroyed tissue is going to result in what is known as systemic acidosis. Now, systemic acidosis is going to add actually to the, pH of the stomach. The pH of the stomach is at 1, which is incredibly acidic. So you bring in the systemic acidosis and you put it in, you weigh it in, and the end result is going to be failure of the defensive mechanisms of the gastric mucosal wall, and that's going to result actually in the formation of a stress ulcer. Something with intracranial injury, in this case, you're going to be finding that there will be direct stimulation of the vagal nuclei, and the result of that is going to be dumping of HCl in larger amounts, direct dumping of HCl in the stomach that is going again to overwhelm the defense mechanisms. What you're going to find here is, multiple smaller in terms of size. They are usually less than 0.5 centimeter in maximum diameter, but they are deep, when it comes to, if you want to measure, they are deeper than the acute erosive gastritis. And, one of the things that you're going to find here is that there will be no kind of long-term, damage. So if you take a section of this ulcer and you look under the microscope, you will not see any kind of fibrosis actually in the lamina propria. You look at the area surrounding the stress ulcers, and you will see that it is completely, normal. That there is what we call direct interruption or sudden interruption, sudden movement from a normal mucosa to the stress ulcer. So there is no intervening phase. Intervening phase usually tells you that the process is ongoing and that probably this is going to become chronic. Here, there is simply, as you will see in this picture, you look at the nearby mucosa and it is completely normal, and all of a sudden you see these lesions. You can see that they are pretty small, multiple. If you cut it at the level of these ulcers and you look from the side, what you call sideways, you will see that it is deeper than actually acute erosive gastritis. All right, so this is the mechanisms. All right, so, and we talked about how the NSAIDs does it, through the cyclooxygenase suppression, and that's going to prevent the prostaglandin, preventing also the vasodilation and the HCO3 secretion. Intracranial injury with direct stimulation of the vagal nerve, and that causes actually, that will overwhelm the defense mechanism, and systemic acidosis. We mentioned all of that. All right, so these are actually the lesions. A lot of autopsies, usually it's something that happens in extreme, conditions. And a lot of patients actually, just before they die, they will be, exposed to this kind of, changes at the level of their stomach. It did not cause their death, simply it shows that they were going through a very severe stress that resulted in these stress ulcers. All right, so now coming to the result, going into the ladder, into the real deal, now into chronic gastritis. All right, so what's happening with chronic gastritis is that you're going to be finding it's caused by one of two major causes. There are other causes, but remember, the acidity of the stomach is both actually, is a double-edged sword if you want to think about it. It will take care of a lot of pathogen, okay? And it will destroy it before it causes any kind of damage to the stomach or to the GI in general. But actually, itself, the acid itself, if it finds its way into the gastric wall, as I mentioned to you, that is all that is needed really to cause damage to the gastric mucosal wall. So two major events, Helicobacter pylori and the autoimmune gastritis. The most common cause of chronic gastritis is the H. pylori. And in the absence of H. pylori, let's say, you had a question saying, what is the most common cause of chronic gastritis? In the absence of H. pylori infection, that's going to be autoimmune gastritis. That is going to come second. Of course, when I mentioned you coming in second, that's going to be the US. Okay, this is in the US because this is from Robbins or from Golgian. Both of them are US-based books. All right, so even though we started with chronic gastritis, does that mean that H. pylori does not actually cause acute gastritis? The answer to that, it does actually. Okay, it does, but you'll see that the acute gastritis in this case maybe actually is not so clinically stark as to like what do you call it, make the patient present to the ER, or make the doctor actually work up the diagnosis in the patient and reach a diagnosis of acute gastritis with H. pylori. Okay, so there is an initial event. Always, whenever you see chronic hepatitis, there was always actually acute hepatitis that started, early on, that becomes chronic eventually. Exactly the same exact thing right here. Even though it is mentioned, it is, it's going to present to you, and it is listed here as chronic gastritis. Still, that there is an acute counterpart that happens, that may actually be what you call subclinical, subacute kind of presentation. All right, so you will see how to differentiate between the two, how to differentiate between acute gastritis and chronic gastritis, or acute superimposed on chronic. In terms of clinical, of course, the clinical presentation is going to be, pretty important in this case. For example, autoimmune gastritis is an autoimmune disease. Your patient is going to be most likely female, who's going to be coming in with, again, other kind of autoimmune diseases, vitiligo, diabetes, thyroiditis, autoimmune thyroiditis, and so on and so forth. Now, in the H. pylori, you will hear also a story about actually ingestion of possible contaminated food, and that is going to be followed by the classic presentation of acute gastritis. But all of that is not going to cut it. However, pathology actually, if you get to the point where you have to differentiate, at the level of tissue between acute versus chronic, pathology is going to deliver the day. In this case, you will see that chronic gastritis will be associated with mucosal glandular atrophy, with epithelial metaplasia, and with absence of erosions. Okay, things that you will not find in acute gastritis. Right, in the long run, even though it may start as a relatively benign process, this may actually go on to become very serious kind of presentation, whether for chronic gastritis with autoimmune cause or with H. pylori. So in the long run, it may actually be causing carcinoid, and or marginal zone lymphoma, known also as the multoma, the mucosal associated lymphoid tissue lymphoma. Starting with this is what I meant to you when I opened this lecture by telling you to remember that actually the cardia and the antrum, those are cells that are rich in mucus. Okay, now you will see that in this case the antrum is the area that is favored by the H. pylori. Okay, and that is going to actually cause very important effects as a result of this kind of infection. On the other hand, autoimmune gastritis is going to be mostly focusing on the fundus, on the area where the HCl is produced, right? The HCl and the intrinsic factors are produced, very important things as well. So remember, autoimmune, you can even add it actually to it, autoimmune fundic gastritis versus H. pylori antral gastritis, and we will see why is that important in a second, right here. Starting with the chronic autoimmune gastritis. As you can see here, it's a fundic type, so it's autoimmune in nature and involves the body and the fundus. These are the cells, this is where the cells of HCl and intrinsic factors are actually present, okay? So as a result of that, you will have less IR, right? Less intrinsic less intrinsic factor. And as you know, the vitamin B12 is going to couple up with the intrinsic factor that is going to be absorbed at the level of the distal ileum. Okay, so when you don't have the IF present as a result of the destruction of the cells that actually produce the IF, the end result is going to be there is going to be malabsorption. There is going to be deficiency in the absorption of vitamin B12, and that specific condition is known as pernicious anemia. Okay, so no other cause of vitamin B12 deficiency is going to be called pernicious anemia, even though all of them are going to result in megaloblastic anemia. Okay, the pernicious anemia pertains only to the megaloblastic anemia that results from the autoimmune destruction of the parietal cells in the gastric wall. Very important point to be made. Okay, are there any other causes of vitamin B12 deficiency that comes to your mind? Diet. I don't think diet is the cause. Why is that the case? How long does it take someone actually, let's say someone, decides to go on a crash diet, and he will start to tell himself, I'm not going to be eating anything that is meat, right? This is what you mean by that. How long does it take him actually to, develop vitamin B12 deficiency? 5 years? You guys are
That's a lot.
surgeons. Not 5 years, less.
2 years. 1 year. 1 year. 6 months.
Yeah, either 5 years or 3 years. 1,000 days, remember that. 1,000 days, because the liver has actually stored amounts, large amounts of vitamin B12 for 1,000 days, 3 years. How many days, let's say that actually you are the carnivore type, right? And you started to tell yourself, I'm not going to be eating anything except meat, okay? So you will give up all the fresh, the fresh greenish, food, altogether. How long does it take you actually to develop folate deficiency? How many?
1 day.
1 week?
Yeah.
You're really not appreciating the how good the human body is, how amazing really the human body is.
A month, 3 months.
3 months, exactly. So remember this, 100 days, 1,000 days. So 3 months versus 3 years. So which one is going to be more likely to actually be deficient first? Folate acid. Okay. Now here's a question for you. So what results actually as a result of vitamin B12 deficiency? Okay. You will start to see some kind of, changes at the level of the CNS. You guys have already actually taken a step back. Before that, I asked you what other causes. So, diet in the long run, I will agree with you. What other thing than diet? But so take out part of the ileum. Absolutely, that's okay. Part of the ileum or part of the stomach, right? Take out the stomach. Something that surgeons do as well. What else actually could cause it?
Autoimmune.
Speak up. Nobody is confident enough to speak up. Fadal. Absolutely. Pancreatic insufficiency may cause it as well. What else? How about bacterial overgrowth of the distal ileum? Could that cause it? Absolutely. Parasitic infections, at the level, that infest the distal ileum, another thing that may cause it. How about actually Crohn's disease? Could it cause it? Absolutely. If it involves significant involvement of the distal ileum. Could UC cause it? Ulcerative colitis? Also, yes. If it involves the distal ileum in what is known as backwash ileitis. But you don't need to know the last one. Okay, so now that we have seen this, okay, so what is going to happen at the level of the CNS? This is something that you guys have also studied in the CNS, so you cannot claim that you did not. What will happen as a result of vitamin B12 deficiency at the level of the nervous system in altogether, not just the CNS? Myelination only?
Demyelination.
Demyelination. So what I'm saying, myelination effect. SCD. Okay, what is SCD? Severe combined degeneration of the spinal cord, right? Is that the only thing that happens? No, there is more actually. All right, so what else? Let's see. So severe combined degeneration of the spinal cord. How about this peripheral neuropathy? You mentioned that with demyelination, optic neuropathy, ataxia, cognitive disturbances, and mood changes. What do you call the final three? The cognitive disturbances and mood changes. So in addition to the spinal cord, you have actually what you call neuropsychiatric complications. All right, so so this is actually caused by vitamin B12 deficiency. It causes all of those changes in addition to megaloblastic anemia. What does the folic acid deficiency cause? Does it cause the same?
No.
Who told you no? Who told you no? Well, I was waiting for that. Who told you no? Hemong. Absolutely not. It does. It does. The reason why I mentioned it is because in the 20th century, where most of your faculty has been taught, okay, we learned actually that vitamin B12 deficiency cause SCD and cause all those neuropsychiatric disorders, but folic acid does not cause it. Now we know actually that this is not true, and I have the book actually. It's a book. Once you see something that is listed in a book, you know that this is an established fact, and it's no longer actually a matter of research. It's a neurology book that that mentioned this, and when I checked with other with other, references, it was there as well. So folic acid also does cause it as well. Okay, remember that. Why you fell for this? I did not expect that. Okay, let's talk about actually what do you see in the peripheral smear of someone. What are the cells, that are going to result in megaloblastic anemia? Let me check. Now your hematology, hem-onc again.
Red blood.
What do you see?
Like big, they're gonna be big.
Big RBCs. Wow, this is like what I said. Probably you guys are going to be pathologists, hopefully. Big and ugly, right? This is what the kind of vocabulary that you like to have. So right, but older, usually very older pathologists, not the new early pathologists. So what else would you see other than the big RBCs?
Hypersegmented neutrophils.
Why do you call it megaloblastic anemia? What happened in megaloblastic anemia?
There's one less division.
Where is the problem in megaloblastic anemia? Probably this is the right question. Where is the problem in the megaloblastic anemia? Is it, what is it? Aha, so it's what you call nuclear maturation. What is the problem with the microcytic anemia?
When there is one extra, one extra less iron.
Okay, less iron, blah, blah, blah. What is that? It's a cytoplasmic maturation defect. Remember that. So, what is the cytoplasm of the RBCs? Hemoglobin, right? So globin and iron, right, are all actually in the cytoplasm, right? So it's a cytoplasmic maturation problem. Whereas with megaloblastic anemia, it's a nuclear maturation problem. What happened? What is this nuclear defect that happened in patients with vitamin B12 or folate deficiency?
They divide one step earlier.
They divide what?
One step earlier.
One step earlier? Actually, they divide very many steps later. It's resulting from delayed division. So delayed and fewer division. You see what I'm saying? The end result is going to be what? The end result is going to get less number of cells. So, and also delayed kind of maturation. So as a result of the nuclear maturation defect, you will see that the nucleus is going to be, so the cytoplasm is fine, okay? The cytoplasm is doing everything that it should be doing, for the most part. But the nucleus has not actually decided to divide and then to disappear as it does in the RBCs. And it's going to happen many steps later. So you will see fewer and later division that is going to result in larger, remember this, so this megaloblast, so the nucleus is not dividing, the nucleus is increasing in size, and then actually it is dividing later and fewer. So you will see fewer number of cells and a larger, cells that results from this division. This is why you will have the larger RBC that you see with megaloblastic anemia. So remember, cytoplasmic maturation and nuclear maturation defect. Okay, so let's talk, and is that only limited? So I asked you, what do you see in the peripheral? Let's say that you see a segmented neutrophil in the peripheral smear of someone who has megaloblastic anemia. How will this actually peripheral, the segmented neutrophil look like?
Has a lot of segments.
More hyperlobated, right? I asked you this question before, and you will find here answer this question very, very, very well. So it will have more number. Of course, there's a long list of causes of hypersegmented neutrophils, but this is one of the common ones, especially for medical school sake. What happens if you have less than 3, meaning 1 or 2, lobe of the neutrophil. That's what you call MDS, myelodysplastic syndrome, right? Also, there's a long list of hypolobated neutrophil. So imagine this from the simple, look of actually a cell. You can deduct so many things. Of course, a differential list. It's never really, this is the final diagnosis, but if you add it together, you'll be able to reach that diagnosis, okay? So megaloblastic anemia due to vitamin B12 deficiency, achlorohydria. Achlorohydria, why? Because actually there is destruction of the parietal cells. What happens as a result of this destruction to the G cells that are present also in the antrum? Hold on, where is this happening? This is happening in the fundus, right? So the antrum is pretty much actually what you call it, spared, okay? So, and the cells of the antrum, by and large, are spare. So, what are, in the antrum, there are the G cells. The G cells that actually mark what? Gastric. So, what happened to them? Why?
Because there is bad acid secretion.
So, the acid was going to suppress this, gastric secretion, right? You take the acid out, and what happened to the gastric secretion? It's going to be through the roof, right? This is one. Two, those cells are going to increase in size as well. They may increase in size so much, it may actually result in the formation of a tumor in the gastric antrum, known as neuroendocrine tumor. G cell neuroendocrine tumor, known as also as, no, Zollinger-Ellison. Zollinger-Ellison is something completely different. It is due to multiple type of gastrinomas, absolutely. Okay, multiple types of gastrinomas. What does gastrin do? Stimulate acid secretion, right? This is why actually it started to happen. What happened in Zollinger-Ellison syndrome? You will see that there will be what you call intractable ulcers pretty much everywhere. In a lot of places in the GI tract, right? And those are intractable because the only way to treat them will be what? If you take out these tumors, right? These gastrinoma tumors. So the question is now, what happens in a patient who have a chlorhydria? The gastrin is going to be through the stratosphere, right? Hypergastrinemia. Do you have that in folate deficiency? No. Do you have that in bacterial overgrowth of the distal ileum? Also no. Do you have that in surgical resection of the ileum? No. In parasitic infection of the ileum? No. So all of this, with the exception of the gastric resection, so gastric resection and autoimmune gastritis are going to be the only two causes. No, I take that back. Gastric resection, you're taking, if you have not spared the antrum and you took the cells of the antrum, there will be no hypergastrinemia, right? So the only actually condition where you will see hypergastrinemia is by and large going to be in chronic gastritis setting is going to be autoimmune gastritis. So that's a very important distinctive feature between autoimmune gastritis and H. pylori. Okay, are you guys with me? Did I lose you somewhere? All right, hopefully not. All right, so in addition to the carcinoid that we have just talked about, this neuroendocrine tumor that may arise as a result of the G cell hyperplasia, there's also increased risk of gastric adenocarcinoma. You guys want to take 5 minutes break? Okay. Let's see what am I. Right. There's a lot to cover, obviously. Don't worry, we'll fly. Thank you. All right, so now testing for autoimmune gastritis. Testing for autoimmune gastritis, like all other actually autoimmune diseases, you see there will be increased IgG levels. This is one. It used to be that we do serology, but we have gotten to the point in time where we know that serology testing, looking for antibodies directed against the parietal cells, is going to be a moot point. Unfortunately, you still do it. Everywhere you go, you do it. The problem is with the antibodies is that there is a subset of patients who carry the antibodies, a significant subset, around maybe 15%, 20%. Of patients who carry the autoantibodies, but they don't have the disease. Okay, and there's another subset where you are not able to actually detect autoantibodies in a patient with pernicious anemia. Okay, so you see all the signs and symptoms of even the lab signs of pernicious anemia missing the antibodies. When you see a test like this, it's negative when you expect it to be positive. and vice versa, that takes away actually from the strength of the test. So as a result of that, a lot of places will tell you that they will do it, but they will only look at it with a grain of salt. Why? Because of the reasons I mentioned to you. Now, better tests are going to be low levels of serum B12, absolutely. And there is, high levels of homocysteine and also high methylmalonic acid level, okay? Now, why is the methylmalonic acid level increased in patients with autoimmune gastritis with vitamin B12 deficiency? Who said that? Coenzyme for? Sorry. Exactly. So it's the B12 is a cofactor actually, coenzyme for the reaction that is going to work on the methylmalonic acid, and as a result of that, the methylmalonic acid level is going to be significant. Now, to show you actually, again, why pathology, which is a specialty that is not really very entrenched in the Middle East, unfortunately, for many reasons. We'll look at a thing and they will decide that this is not really the real test. So you look at the low B12 serum level. If you look at the parameters of the low B12, you will see that it is a pretty wide parameters. Could someone check what are the normal levels of vitamin B12 for me and tell me here? I think it was like something like 20 to 260. Anybody? You guys are all equipped with the best kind of, right? With the best kind of, what is it?
160 to 950.
Say it again. 160 to? Can you speak up, please? Like your voice. 160 to 950. That's a huge range, right? How do you know that someone actually is not, having his vitamin B12 level decreasing? Meaning, let's say he was actually 700 last month, and today he is 450. Is he decreasing or not? He is decreasing, right? But it is still normal, right? So what to do? In this case, you look at the methylmalonic acid level, and that is going to nail it for you because it's far more sensitive and have a more precise range than the low serum B12 level. Okay, so just again, this is what you call a pitch sale for my specialty pathology. I badmouth them so much, I tell myself I need to not do that. Okay, but again, I'm part of the specialty, so I feel like I do have certain rights to do that. We did talk about the associations right here. Okay, now we move on to the next one, which is chronic gastritis with Helicobacter pylori. All right, so acute infection does exist, but unfortunately, for the most part, it goes unnoticed. Why, unfortunately? Because usually it is the acute infection part of the disease that is going to raise, the concern in the mind of the person concerned, and then goes, to see a doctor to get the workup and to reach a diagnosis, hopefully, if it's a good hospital, a good clinic, that is, okay? That does not happen always, as you know, but the hope that it does actually, that this is the course of events. An acute event, pain is a blessing, is not really a curse, if you really think about it, because at the end of the day, it will, manage to save you from other, more significant kind of complications. Now, so acute infection is not there. It is the chronic infection that produces the symptoms, not just symptoms, but really very significant, complications, as we will talk about, and that you need to pay attention to, and that you need to treat very, adequately in order to eradicate this organism. So H. pylori is present in about 90% of patients with chronic gastritis affecting the antrum. If you say H. pylori in the stomach, in any stomach disorder, most of the time you're going to be right, actually, because it is involved in pretty much everything, from gastritis to peptic ulceration to lymphoma to carcinoma development. Right. In addition, increase acid secretion seen, H. pylori may result in peptic ulceration. We'll see. We'll talk about that in a second. So we'll talk about actually the pathology, the pathogenesis of H. pylori. So imagine this in the US, a place where they have a very strong public health department, pretty much all over the cities and states in the US. 30 to 50% prevalence rates of H. pylori infection in US population. That tells you what? What is the conclusion that you deduct from this? There are a lot of people eating out, right? Because imagine this, it's a very fun thing. It's a fecal oral route kind of transmission. Okay. So you can imagine that. And it's common area post sanitation, a lot of fun stuff, really. And all of it you can actually take to the take-home message, which is cook your own food. Nothing is clearer than this, right? But I stopped actually giving any public health advice because it seems it's not working. All right, so imagine this surviving in a pH of 1. How about that? I mean, you need to give credit for the H. pylori, and it does it in a very, colorful, really, and a sophisticated kind of way. So gram-negative curved rod, it produces urease. You guys will either have gotten or will get this in microbiology, and for the sake of no overlap, I will be, skipping over most of this slide. However, I will mention to you that this urease is going to convert the amino group into ammonia, and this ammonia is going to act as a cloak. A cloak. Well, you know what a cloak is? CLOAK. What does it mean in Arabic? Say it again. Aba'a. Who said that? Good. Absolutely. Aba'a. It's going to cause actually a shell or aba'a around this, and that is going to ameliorate the effect of the acid on the bacteria. How about that? It also actually has, what you call flagella. The flagella, let's say that in the stomach itself, there are areas that are more, acidic than other areas. If the organism finds itself that it is in one area that is really, really, hyperacidic, this flagella is going to help it move to other areas that are less. So another way for that to happen. And 3, actually, it does not dig deep into the, into the epithelium. It is there, on the, in the mucous cell layer. So it gets embedded in the mucous cell layer. Imagine this, the mucous cell layer that itself actually is a protection from acid. So it is, now protected with the mucus and protected with the bicarbonate, if you can believe that. So it's using the defense mechanisms of the gastric wall against actually the stomach itself. And in the process of doing so, it will incite a very strong inflammatory response in the gastric mucosal wall that is going to be really the hallmark of this infection. So remember, it does not really dig deep into the epithelium. It's staying on the mucus layer, on the most superficial, on top of the epithelium. And it does all the, effects through actually its presence on the mucus layer. It does not invade. That's really a work of art, if you ask. Now, one thing actually to add to this is the CAG-A. We already agreed, me and the microbiology people, to mention that always cytotoxin associated gene A. It's known actually that those patients who carry the CAG-A, the H. pylori CAG-A with the CAG-A gene, that they are more likely actually to develop peptic ulceration, duodenal ulcer, stomach ulcer, than the rest of the strains. The reason for this is that the CAG-A is going to invite a lot more inflammation and a lot more inflammatory cells to the site of action, because it will render actually this strain able to produce higher amounts and different types of cytokines, pro-inflammatory cytokines. All right, so flagella, as I mentioned to you, urease. Now, once it finds its place where it's going to dig into the mucosal layer, that's actually where is that going to happen with the adhesion and the CAG-A toxin that we have talked about. So, as a result of the above, the balance between the protection and between protection or defense and damage, will be not there anymore, and damage is going to happen to the gastric mucosal wall. Now, one of the things that are going to happen, is that this is, as I mentioned to you, this starts in the antrum, but then eventually it may become actually pan kind of inflammation involving all the stomach, what is going to result in pan gastritis. All right, resulting in, that's when it becomes really, dangerous because it's now engulfing the whole stomach. And the end result is going to be atrophic gastritis, multifocal atrophic gastritis, intestinal metaplasia, and also, possible dysplasia and development of carcinoma or lymphoma. All right, so how does the H. pylori do it? It does it actually through the hyperacidity. How does that happen? As I mentioned to you, it does affect the first, those areas of the antrum. What are the cells of the antrum? Mucus cells, right? So what happened to mucus secretions? It's going to decrease, right? This is one. Two, when it becomes pangastritis, then it's going to be involving the fundus and also the body, right? What is in the fundus and the body? The H. pylori, okay? So it's going to, affect them in a way, with the inflammatory cells that are going to be brought to the sites that are going to irritate those cells. And as a result of that, it will make those cells put out more acid, resulting in hyperacidity. Okay? So hyperacidity, less mucus, and, the balance has been tilted already. There's also thrombotic occlusion of the surface capillaries that is going to result in necrosis and will aggravate the injury. And if it's a CAG-A kind of, series, it's going to result in inviting and making a lot more pro-inflammatory cytokines and different, types of pro-inflammatory cytokines than other strains that will invite more cells to the site of action. So this is how H. pylori will do it. Here is an example of that. This is, and for those people of you who actually live by the coast, I know a couple right here. All right, so you can see that there is what you call a seagull appearance. What's a seagull? It's a bird, absolutely. What kind of bird? What's the Arabic word for it? A noras, exactly. Very good. Wow, I'm impressed. Okay, a noras, and you can see where these noras are, right? They are right there on the superficial cell layer, maybe barely in the top, gastric foveolar cells, but they don't dig deep into the gastric wall at all. All the fun they do, actually, all the damage they do is from this area right here. That's what you call probably like a sniper kind of action. It's, it stays back and it allows everything that it is producing, cytokines, inflammatory cells, to do the business for it. So you can imagine actually how much, of inflammation this is causing. What are these cells that are actually, having this peripherally located nuclei that are, okay, Russell bodies. I love that very much. Thank you. Russell bodies. So Russell bodies in what kind of cells? Plasma cells. Okay. What do you call those plasma cells? So you got the Russell bodies right. What do you call the plasma cells that carry the Russell bodies? We call them MOT cells, M-O-T cells. Okay, so now you can see actually that those plasma cells, which usually you don't see them in that number, or you don't see them inspissated with these, large globules that your good friend here had actually managed to call correctly as Russell bodies. What are these Russell bodies? Immunoglobulins. Okay, immunoglobulins that are waiting to be actually going into the action against the bacteria. But in the process of doing so, it will damage. See, inflammation is good, really good. Why? Because it's going to go after the bacteria. But if inflammation does not actually succeed in eradicating the bacteria, inflammation itself becomes, a weapon against the tissue itself. And in this case, it is not able to eradicate it. And that's when the good doctor, you guys, will have to interfere and to give treatment. It used to be triple treatment. Now there's a quadruple treatment for the H. pylori infection. All right, here's actually chronic atrophic gastritis. What is the usual appearance, the usual gross appearance of the stomach? When you cut it, the way to cut it, pathology cutting, is that you cut it along the greater curvature and then you open it up like this, like a book. How does it look like when you cut it along the greater curvature? As a what? Well, I'm not asking about the rogue. How about, the overall, appearance of it? Butterfly, as a butterfly, right? As a butterfly, exactly as a. Does that look to you like a butterfly? It does not. It looks butterfly or rectangular, right? What is this? A triangle, right? So you can imagine how much tissue was lost as a result of the repeated bouts of inflammation, correct? Now, if you take a section of this, and your good friend here mentioned, the loss of rogale, absolutely, rogale folds, that distinguish the stomach is no longer there. Now, look at this. All right, so look at this. This is normal. This is how thick actually the normal mucosa look like. How thick and what you call it, rich really. The normal mucosa, mucosal wall looks like the epithelium. Look how thinned out this is actually. There is denuded mucosal wall right here. In addition to this, you see these dark structures. What are they? These are actually collections of chronic inflammatory cells, in this case, lymphocytes and plasma cells, that start to organize, giving the feature of what looks like pseudofollicles, okay? Pseudofollicles, it is at the level of those pseudofollicles that a lymphoma actually may set sharp. And we will see how that happens in the next few slides. Okay, here it is. So this is the warty starry stain, silver stain, that is going to pick up those seagulls. So all of these dark structures are seagulls. Again, you see that they are going to be true to their nature. They are still at the mucosal cell layer, at the superficial cell layer. Now, in addition to this, you see here, this is again a chronic gastritis. You start to see that in addition to the chronic inflammatory cells and the plasma cells, there are also neutrophils. And the neutrophils have managed to go through the basement membrane and into the epithelium and into some of the pits, creating what is known as pit abscesses. Pit abscesses. Remember, this is something that you will not find in acute gastritis, but you will see it in chronic gastritis. In addition to this, you start to see the collection of this lymphoid tissue, what looks like, pseudofollicles. It may fool someone into thinking that this is actually a true follicle. It's not. So pseudofollicles that are accumulating in the mucosal layer. Now, how does lymphoma come to happen? When those cells, when the inflammatory cells start to attack the epithelium and start to destroy the epithelium. That's what you call actually a lymphoepithelial lesion, which is the pathognomonic lesion of this type of lymphoma that may arise in the stomach, which is known as a marginal B-zone lymphoma, or also as a maltoma, mucosal associated lymphoid tissue lymphoma. Now, I did mention to you this in the POD, if you guys still recall. What happens in marginal B-zone lymphoma?
Does the marginal zone appear when there's infection?
Yes, because marginal zone lymphoma could happen in any tissue. Whenever there is lymphocytes and epithelium, and the lymphocytes are attacking the epithelium, creating a lymphoepithelial lesion, that's a marginal zone lymphoma. So it may happen in the skin, it may happen in the stomach, it may happen in other tissue. So now, but what is the question that I meant? What is the thing that I mentioned to you about gastric marginal B-zone lymphoma and POD? I told you that it is one of the examples, for those people who think that tumors are caused by infection. And actually, if you treat marginal B-zone lymphoma with antibiotics, you may be able to revert back, to push back that tumor development and cure your patient. As crazy as this sounds, that's exactly the case, because they call it a very low-grade tumor, a very weak tumor, that in the early stages of transformation, if you treat the patient with a marginal B-zone lymphoma with the quadruple therapy of H. pylori, you will be able to cure that patient, okay? One of the, probably the only times you will ever hear that you are curing, a cancer with antibiotics. Now look at this here. Does that look to you like a gastric kind of epithelium?
No.
With a finger-like, where do you see these fingers? Intestine. Which intestine? Small intestine. Excellent. At least your histology, work in year one is working. Very good. So this is intestine. So this is intestinal metaplasia. Intestinal metaplasia, and what are these cells right here?
Goblet cell.
Goblet cells. So what would you call it here, actually? Let's see if you're going to make it into pathology, man. So intestinal metaplasia and
Finger-like projections.
a goblet cell metaplasia too. So it's intestinal and goblet cell metaplasia. If this continues unabated, eventually those cells will become dysplastic and adenocarcinoma may arise from this. So you have seen now, two actually tumors that may arise as a result of the H. pylori infection. One of them is going to be the marginal B zone lymphoma. The second one is going to be the adenocarcinoma of the stomach with intestinal differentiation. All right, how to identify H. pylori? A very handy kind of test is the urea breath test. But there's a couple of drawbacks when it comes to this. One of them is the fact that actually the test is is more expensive. This is one than the other test, in this case, the stool antigen test. Two, that there are other bacteria in the stomach, in the GI, in the stomach, that actually could convert the amino acids into amino acid groups into ammonia and may fool the test into thinking that it is H. pylori. In reality, it's some other bug. So that's an important actually distinction. But still, sensitivity and specificity more than 90%, very equal to the stool antigen test. Of course, the stool antigen, the stool itself, the word stool is going to be actually in this case, one of the drawbacks of this test. It's a cheaper test and an excellent screen. And both of them gives you exactly what you're looking at: active versus inactive infection, and negative when the infection has been eradicated. All right, now test to detect urease in a gastric biopsy. This is the gold standard, but it is an invasive test, and it's not really done. A lot of times it's a clinical test with one of the lab tests that we just mentioned before actually you reach a diagnosis. Serologic tests, for H. pylori has also been actually discontinued for the same reasons, presence with no infection and presence of infection, but with no antibodies. That's always going to actually be a very strong drawback, about that test. Here is a beautiful actually, table from courtesy of Robbins that is going to, summarize for you pretty much everything that we have talked about. One thing I want to point out to you is going to be the sequela of both conditions. So with the H. pylori infection, H. pylori enteritis, if you will, peptic ulcer, adenocarcinoma lymphoma. This one here, autoimmune, in the body, autoimmune body gastritis. There's atrophy, pernicious anemia, adenocarcinoma, and carcinoid tumor. All right, now peptic ulcer disease. Let's finish first, please, if you have any question at the end. Okay, chronic ulcer. That's a pretty important. Now, most common site is going to be the duodenum. In a significant number of times, it's going to be the duodenum and not the stomach. Why is that the case? Exactly. Thank you very much. The duodenum does not have any protection like the stomach, right? It does not have mucus. It does not have bicarbonate. It does not have this rich, robust, vascular network. So sure, it's going to be the first thing that's going to happen. And the bad part about the duodenum is that it's in direct continuity with the stomach. So every time there is an increased acidity of the stomach, it will end up in one of two places, right? What are these two places? Esophagus with GERD, right? GERD, gastroesophageal reflux disease, or the duodenum with peptic ulceration, right? So one of the two. There are other sites for this, including the margins of gastrojejunostomy, multiple sites with Zollinger-Ellison syndrome, and within the ectopic gastric mucosa of Michel's diverticulum. Remember, all of those actually are without the protection of the gastric wall. So, for example, with regard to Michel's, it may be actually the opening salvo, open presenting symptom of Michel's diverticulum, because of the fact that you don't have any of the defense mechanism. The end result is going to be ulceration and perforation of the intestine in this case. Here is an example. Again, if you say H. pylori in the stomach, you're going to be right. Here is actually the H. pylori right here in a patient with the H. pylori in the stomach, with a patient with duodenal ulcer, as you can see here in the first part of the duodenum. You can see that this ulcer is pretty clean, right? Look at the borders, very sharp borders. It's not really that large, probably around 1.5 centimeter. Borders are clear. If you have to take it from me, if you cut it and look on the side, you will see that the edges of this ulcer is on a level with the rest of the mucosa. So there is no what is known as heat up margin. Okay. And all of those actually, and you look at the pit, and the pit looks fine actually for the most part. So all of these are features of benign ulcer. Most of about 99% of the ulcers in the stomach, in the duodenum, I'm sorry, are benign. Okay, this is why you will see that for the most part, they do not really need any endoscopy and they don't need any biopsy for those. Now, the problem, comes when there is a gastric ulcer. And at one point in time, we thought that all gastric ulcers are tumors. And we know now that this is not the case, and that the number of actually gastric ulcers that are actually cancers is about less than 10%. Some people say less than 5%, depending on the study that you are going to read. So what happened is that there is a mix-up because there are certain gastric tumors that will be ulcerated, okay, that will be mixed up or confused for malignant gastric ulcers. Okay, it's not the same. It's the tumor that becomes ulcerated versus an ulcer that is malignant. Very different kinds of. At any rate, any one of those actually may be perforating or undergo perforation, and the result of that, you will see that there is, an air that becomes present under the diaphragm, as you can see here. Look at these two bubbles of air under the diaphragm as a result of perforation, which is one of the complications of peptic ulcer. H. pylori, as I mentioned to you, the cause of PUD in 70% of the cases in the US and about 90% of the cases worldwide. All right, eradication of H. pylori eradicates PUD recurrence. Imagine this, that's pretty important to remember. So when you deal with the PUD, you need to remember that you need also to take care of any kind of H. pylori infection that may be still there. Duodenal ulcer are more common than gastric ulcer for the reasons that we have talked about. Risk of bleeding is the same in both, and the location, the duodenum, is the 90% of the time, for this kind of ulcer. And the same exact way of this is doing it. It's the hyperacidity, and we talked how this come to happen. The thrombotic occlusion of the surface capillary and the pro-inflammatory cytokines. So whether gastritis or PUD, it is exactly the same. Pathogenesis, the H. pylori will follow in order to induce damage to the gastric wall. And once there is hyperacidity and that hyperacidity is delivered to the duodenum, all bets are off because the duodenum does not have the defense mechanisms the gastric wall is having. So very important, H. pylori is implicated in gastritis, peptic ulcer disease, gastric cancers, and lymphomas. They need to give this bug a medal, really, if you ask about it. It can do a lot of things. There's a word multi, something about, actually, it can manage to do many things at the same time. All right, so, gross features of a benign gastric ulcers, I just mentioned to you. It's so important, actually, it is, even though the number of the percentage of gastric ulcer that may be malignant is really small, but you still have to do it. You cannot leave things at their own. You will scope the patient, you will do upper endoscopy. And if you see these features, that's going to be actually more benign than malignant. So less than 4 centimeters in diameter, clean pit, very, punched out borders, very clear-cut borders, margins in level with the rest of the mucosa, and the rugal folds radiate from the ulcer in a spoke-like fashion, like wheel. Here is actually example for you of a benign gastric ulcer. Clear-cut borders, spoke radiation of the rugal folds on, even out, level with the rest of the mucosa, and it's not really that large, about 1.3, 1.5 centimeter maximum diameter. All of these are features of a benign gastric ulcer. Here's a beautiful table, also courtesy of Robbins for you, so that you can actually go over it and see what we have missed in this lecture. And finally, the presentation. Of course, I leave all of this to the clinicians. God forbid I will ever go into this. But the clinicians have, for some reason, they love to go into pathology. I don't know why. Intractable pain, bleeding, perforation, and obstruction. That's, of course, obstruction when that's going to depend for the most part on where the ulcer is happening. That's going to be mostly actually with antral/pylorial kind of ulcers. All right, we finished this. Oh, we're done actually. So you guys have to give me 1 more hour somehow. Yeah. What is it now? 40, right? Now we have 20. Let's see if we can do it. Okay. Instead of 1 hour, let's see if we can do it in 20 minutes. How about that? Okay, gastric polyp. Hey, easy. We'll finish. Hopefully, we'll finish. 20 minutes. The clock here is wrong. So, gastric polyps. We're talking about tumors now. Gastric polyps, a couple of types of polyps. And if you look, the underlying theme really is going to be, for the most part, inflammation, what we call inflammatory polyps, whether in the course of H. pylori or other kind of inflammation. All right, so these are masses or nodules that are going to rise above the rest of the epithelium, will hang there, either actually with a neck or without a neck, sessile or pedunculated. And the most common type is the inflammatory type, starting with the inflammatory or the hyperplastic type. For a long period of time, we thought that if you say the word hyperplastic, that is actually equivalent to always benign. Now we know that this is not really the case, even when it comes to hyperplastic polyps of the stomach. And we know now actually that this is from epidemiologic evidence that the larger polyps, more than 1.5 centimeter in maximum diameter, are going to harbor a higher risk of dysplasia and malignancy than the smaller ones. Okay, associated with H. pylori may regress with treatment. So what you call also another name for it is inflammatory polyp. If you look at the location within the stomach where this happened, most likely is going to happen in the antrum, and the size of most of those types of polyps are less than 1 centimeter in diameter. Predominant histology is that of enlarged, dilated foveolar mucosal epithelium. All right, so now you have gotten the inflammatory polyp, inflammatory hyperplastic polyp. Fundic polyp, on the other hand, again from epidemiologic evidence, I love when Robbins or Dolgen stick their neck and make a statement for crying out loud once, and have what you call kahuna. When they come to you and tell you does not have neoplastic potential, that does not happen a lot of times in medicine, right? Because most of the time medicine will play like wishy-washy, like will go 1 step further and 2 steps back, right? In reality here, they do actually step forward and stick out their neck and say do not have neoplastic potential. That's pretty good. Now the mechanism is this: they have actually found out that the fundic type polyps are increasing in incidence, and they have linked this increasing incidence to the treatment with the proton pump inhibitors. So any actually mechanism that is going to decrease, most likely due to increased gastrin secretion. So anything that is going to decrease acidity, and the most common cause of decreasing acidity is going to be something that you do iatrogenically with treatment of the H. pylori, right? So again, H. pylori is there somewhere. H. pylori treatment, quadruple therapy, and within this antibiotic list of medications you give your patient, you give them also the proton pump inhibitors, and that's going to decrease the acidity. And in the process of doing so, gastrin is going to increase, and as a result of that, those type of polyps are going to be appearing in the fundus of those patients. Now, in terms of actually the lining of and what type of glands that make up this polyp, it is made up of dilated glands and microcysts lined by fundic mucosa. So it's a fundic mucosa that's going to be there. For the most part, sporadic, meaning 1 or 2, pretty much, unless you see a patient with the FAP, the familial adenomatous polyposis syndrome, that's when they will start to have multiple polyps, a large number of polyps of the same type in the stomach. More likely to happen in women, and the association with the with the anti-acidic, treatments. Gastric adenoma. So now we are going higher in the scale. We are getting promoted right now into the real deal, gastric adenomas. You will see that gastric adenomas have the same distribution, with cancer. This is one. Two, there is association with inflammation as well, with H. pylori or with other types of inflammation. And in the process of the chronic inflammation that sets, sharp, you will see that there is going to be atrophy and intestinal metaplasia, which is going to set the stage for malignant transformation. Older males may likely to happen than females. A risk of progress is going again to be linked to the size of the tumor. We have seen that adenomas that are greater than 2 centimeters are more likely actually to develop into gastric adenocarcinoma. In about 30% of the time, there is concurrent presence of gastric adenomas and gastric adenocarcinomas, most likely to be present in the antrum. And all gastric adenomas have a degree of dysplasia, low-grade dysplasia versus high-grade dysplasia. Here's an example of that. So for the most part, they are single, large lesions. Some of them are pedunculated, some of them are sessile, and most commonly presenting in the antrum. We'll talk about cytology, the architecture and the cytology in a second. So you can see here actually a beautiful picture of a gastric adenoma with an development of an adenocarcinoma in it. So the lower part is the gastric adenoma. If you look at the size and the shape of these nuclei, what does these nuclei remind you of? Especially for those of you who smoke, hopefully not the right side, the left side. What does it remind you of? Cigar-shaped nuclei, absolutely. Cigar-shaped nuclei. But you still see some cytoplasm here, right? So the NC ratio have increased definitely from normal mucosa, but there is still some cytoplasm. Imagine this kind of abrupt moving from this section right here to this section in the same tumor, in the same section, from this area to this area. And now what happened to those nuclei here? They are larger. Do you agree with that? How about the amount of cytoplasm? Is it still as abundant as here? All right, so you have less cytoplasm here. You have to agree that you have no choice. That actually there is less cytoplasm here, okay? Less cytoplasm here, but there is no invasion. How would you decide invasion? What do you look at to decide if you have invasion or not? Two things. Either vascular lymphatic invasion, and you don't have anything here, that probably nothing here that is going in the form of a vessel, but you have here what looks like a papilla, right? And the papilla itself, you have any cell that is invading in the papilla, group of tumor cells that are invading this papillary structure right here that is present here, then you would call it actually invasion, and that is not happening. So it is still what you call intramucosal carcinoma. It's still, in a way, you're calling it carcinoma in situ. It did not really invade, any nearby structure. It did not even invade the rest of the adenoma that it has arisen from. It has arisen from a part of the carcinoma, and it may actually, now spread to the rest of it. But from this section, you could not say that because there are no signs of invasion that you are looking at. But it is definitely a carcinoma. And I think that, the cytological features between this and this are pretty clear. There is a lot more disorganization here. You start to see the nuclei piling up, what you call nuclear palisading. As opposed to here. Here there is, some piling up, but definitely not as much as you see here. Look at the nuclear dysplasia. The nuclear membranes are a lot more dysplastic, a lot more irregular. There are a lot more mitosis in the most upper layer. Every time you see actually a space right here, that is a mitosis, and the mitoses are not limited to the basal cell layer. So a lot more than what you see even in the adenoma. So this is a carcinoma in situ, also known as intramucosal carcinoma. Now, gastric carcinoma, coming to the real deal. High incidence in Japan because the Japanese like to live the nice life, right? They like to eat a lot of actually salty food, a lot of smoked food, okay? But in the process of doing so, there is a price to pay down the road. As you know, there is always a price that you have to pay down the road, unfortunately. And in the US, gastric cancer rate dropped by 85%, thankfully, and that reflects actually the changes in the diet, from, the pickled, salty smoked food that they used to take. So let's say that they used to actually barbecue 20 times a month. Now they barbecue only about 4 times a month, which is not really a lot. All right. And, but so everything is dropping in terms of incidence of gastric carcinoma, except in one side of the stomach, which is the cardia, which may reflect actually the increased incidence of Barrett's esophagus and the development of adenocarcinoma of the esophagus that may involve the cardiac region in the process and may be counted as actually carcinoma of the cardiac, the cardia of the stomach. Age about 50 years of age and about 20% 5-year survival. Very dismal, survival rate. The reason for this is that it is growing in this large organ, relatively hollow organ. Okay, and as a result of that, it may attain very large size before it becomes symptomatic. All right, 2 types. There is the diffuse type, which is going to be mostly actually due to a mutation, or some kind of alteration, epigenetic alteration in the CDH1 gene, the CDH1 gene that codes for the E-cadherin. What does E-cadherin do? It keeps the cells together, right? When you weaken E-cadherin, what happens to the cell? The cell starts to become shaky, right? And if you break it, the adherence junctional proteins, in addition to the tight junctional proteins, those cells are going to be free to go wherever they want to go. So, of course, there are other events that happened before that resulted in transformation of this cell into a malignant cell. But for a diffuse gastric carcinoma to happen, the adherence junctional proteins and the tight junctional proteins are going to be affected. And about 50% of the time, they found mutation in the CDH1. And in the other 50% of the time, they found that there is some epigenetic alteration in the form of methylation of the E-cadherin that is going to render the E-cadherin dysfunctional, allowing the cell to simply break off from the rest of the tissue and go on its own way. Now, on the other hand, there is the intestinal type gastric carcinoma. Intestinal type gastric carcinoma, usually in patients with familial adenomatous polyposis syndrome with acquired mutation in the beta-catenin gene. What does beta-catenin do? Anybody who's interested in who done research, actually not by his 3rd year, a lot of you have gone to the US, done spirit, so you would expect. So this is a nuclear transcription factor. Okay, so what do you expect the kind of mutation in the beta-catenin in this case? Activating mutation, right? Because it's going to put the cell in a hyperdrive of division, right? How about microsatellite instability? What does that one do? DNA repair enzymes. If you mess up the DNA repair enzymes, tumors will happen, right? We have talked about this actually in the POD, if you guys still remember. Hypermethylation of the genes encoding the BAX and the BAC and the IGFR2. What's BAX and BAC? Pro-apoptosis. So what do you think actually those mutations here, are they going to be this hypermethylation, not the mutation? This epigenetic, so hypermethylation is epigenetic changes at the level of the genome. So what do you think the hypermethylation will do? Will it result in activating this gene or deactivating it, right? Suppressing, knocking down this gene. Okay, and what about the IGFR2? What IGFR stands for? Insulin growth factor receptor 2. So in this case, what does the IGFR going to do? What does it resemble in its action?
Insulin.
Insulin, exactly. Very good. Very good. All right. So in this case, it's going to actually show up. And in this case, is it going to be activating or deactivating? Activating, absolutely. P53 mutation could be found in both. And the H. pylori infection is not going to be far away here and is a known risk factor for the chronic. Why does chronic inflammation result in malignant transformation? What is it? The chronic inflammation, yes, intestinal metaplasia, but there is even like I'm asking you about the underlying etiology.
Damage and regeneration.
Damage and regeneration. Okay, that's what you call a legal answer. You're right, but that's not what I'm looking at. So what happens actually with the cell cycle? Increasing cell cycle speed, right? And as a result of the increased cell cycle speed, there will be less likelihood that those guardian of the genomes will be able to catch a mutation that may actually escape and may become at one point in time what you call a meaningful mutation, resulting in malignant transformation. So it is really the cell cycle speed that's going to increase in chronic inflammation as a result of the high turnover rate of cells. Epstein-Barr, also this highly oncogenic virus, is about 10% of gastric carcinoma associated with EBV infection. All right, so lower socioeconomic, some of the risk factors or associated factors with gastric carcinoma. Lower socioeconomic status, H. pylori infection. The star is the chronic atrophic gastritis, 5-folds. Pernicious anemia, 15-folds increased, chances of development of gastric carcinoma in those patients with autoimmune gastritis. Of course, diet, all the good stuff that, if you ask yourself, what is left? Very little is left, really. Nitrites, smoked foods, pickled vegetables, excessive salt. They have covered all their bases. Decreased intake of fresh vegetables and fruits. How about that? And family history as well. I don't know if you can live with, if you take everything that is listed here out of your life and continue living, you should really get a prize for that. All right, clinical features, the weight loss is the most common symptom the patient is going to present with that. Why do you think a patient with gastric adenocarcinoma is going to present with weight loss? So first, there's, of course, the systemic effects of the cacectin, right? This is from the POD, cacectin. What else actually is going to be there? Early? Who said that? Excellent. Early satiety. Remember, there is a mass growing in the stomach. This guy is going to be actually stopping eating very early in his like course of food because of the fact that, physically speaking, he is satiated. Occult bleeding. Here is actually a question. For some reason, they bring it year after year in all types of exams because they want you to remember it. Any kind of new onset of iron deficiency anemia in someone above 50 years of age, okay, new onset of iron deficiency anemia and someone above 50 years of age is a, excuse me. Yes, Victor. You need 10-15 minutes. Okay, great. Well, I'm gonna. Yes, I will let them know. So yes, I will. I'm with them now. Thank you. Both lectures today. Hello, I'm sure. Yes, Lamo, Prof. Thank you so much. All right. So Dr. Price is going to be late 10-15 minutes, which is good for me because we will finish our lectures today. So you have no. Oh, we're almost done, guys. So don't worry about that part. He's going to be here. Don't go. He's going to be late. 10-15 minutes. I apologize for that, but we'll use those minutes. All right. So any new onset of iron deficiency anemia in a male or a female above 50 years of age is actually an occult GI cancer, either the colon or actually the stomach, until proven otherwise. So you need to work up your patient for this. This is your first differential and most important differential in this case. How about this? Half of the patients present with palpable tumor that actually is definitely confirming what I just mentioned to you. It's growing, in this whole organ until it reaches a large size before it manifests. All right, location, pylorus and antrum, growth types, there's the excavated, which is going to be the ulcerative, the flat or depressed, the Linitis plastica or the leather bottle, and the exophytic, which is protruding cauliflower-like mass. Now, one thing I will tell you about the flat or depressed, a lot of times you don't really see, any kind of changes in the mucosa. But upon sectioning of the gastric wall, you will see that it is thickened. It looks like a leather bottle, the skin of a leather bottle, and we will talk about that in a second. This is what is meant by the leather bottle. you know, you look at the mucosa is fine. It is not, it has not really, you know, changed in any, you know, kind, in any shape or form, but the submucosa of, you know, of this gastric wall is very thickened. If you take a section of this area under the microscope, you will see this very, you know, distinctive appearance of this diffuse type of gastric carcinoma, known as signet ring cells. Signet ring because the nucleus has been pushed to the edge of the cell as a result of the presence of those mucus droplets in them. Okay, so this is mucin. If you do mucin stain on them, they are going to light up like Christmas tree. Now look at actually this gastric cancer right here. What is, how could you tell me why this is cancer and not benign ulcer?
The edges are not.
They are like a volcano, right? Heaped up edges. That's one too. I know that you guys are not really like, you have not reached the eyes, you know, the guesstimation rights, so to speak, but does it look like a large, you know, lesion? It does look like a large lesion, right? Probably around 3-4 centimeters. So it's pushing the border of benign. How about actually in terms of irregular? Is it regular or is it pretty irregular, right? How about the pit of the ulcer? Is it dirty? Pretty dirty, right? And, you know, again, the heaped up edges is going to give it out. Okay, I need to tell you about that. I cannot help but tell you about this. I had actually one autopsy, which was a very strange autopsy. I did, you know, autopsy this patient looking for, you know, the presumptive, you know, diagnosis, you know, when we went into the autopsy suite was that of a gastric adenocarcinoma. Okay, but in endoscopy they could not look, they could not find it, and also, you know, when they looked, you know, with the CT, they could not really appreciate any kind of discrete mass. So on autopsy, you know, I took out the whole actually esophagus and the stomach, and also the, you know, the intestine, the small and the large intestine, and the bladder. Okay. And we looked at all of those under the, you know, first grossly and two under the microscope. And all those, you know, tissues, the, you know, the mucosal layer was very thickened and very hard. Okay. There seems to be something that happening in the mucosa. You know, one of the differential was actually, could it be something related to systemic sclerosis that may actually be presenting with this kind of, you know, loss of, you know, rugal folds, loss of, you know, all kinds of normal mucosal layers in the body. But, you know, it turned out not to be actually, fibrosis only. It was a desmoplastic response, so it was a fibrous response to the spread of these type of cells, signet ring carcinomas. Signet ring carcinomas that was spread from, you know, from the esophagus, the upper esophagus, all the way to the colon, to the rectum actually of that patient, and also was involving the urinary bladder. When we looked for a primary of this tumor, there was absolutely no lesion that could be identified as the primary lesion in the mucosa in any of those sites. Okay, so it was signed out as signet ring carcinoma with, you know, unknown origin, because we could not really figure it out. And the immunohistochemical panel that we did to figure out, is it from the bladder versus is it from the GI, was very limited at that time, and could not really give us a clear answer about where the origin of the tumor and where it came from. So the Lauren classification, this is the intestinal variant, which is more differentiated. And when you say the word more differentiated, that means actually the assumption is that it's going to behave in a better way than other types of tumors. That may be the case in a large number of cases, but not in all of them. Now, diffuse variant and the signet ring carcinoma is one of those variants. Usually those actually carry, you know, a poorer prognosis, because they are, you know, more aggressive, and they usually spread, you know, in the form of single cell. This is why you're calling it diffuse variant of, you know, gastric adenocarcinoma. Signet ring, right? So, you know, you can see actually what's meant by that. This is the nucleus here. This is the nucleus. The rest of the cell is, is filled with this mucin that is pushing the nucleus to the side. This is the intestinal variant. You can see the intestinal differentiation. Sometimes you may see also goblet cell, metaplasia that we have talked about before in the prior lecture. All right. So in terms of the staging of this tumor, you have early gastric carcinoma that is going to be confined to the mucosa and the submucosa, and advanced gastric carcinoma that is going to extend below the submucosa into the mucosal wall. The spread of gastric carcinoma is actually a very, what you call it, classic kind of spread. It is part of the folklore of medicine. If it's spread to the supraclavicular node, known as the Virchows, node, to the left supraclavicular node, of course, may spread to the ovary, something that we have discussed in POD, what's known as a Krukenberg tumor by direct seeding of the peritoneum, may spread to the skin around the umbilicus, what is known as the sister Mary Joseph nodules. So part of all of them are really very, old kind of names for this kind of presentation. Gastric lymphoma, on the other hand, you have the two types. The most common type in this case is going to be the very low grade marginal zone lymphoma that we have talked about. The pathognomonic lesion is going to be the lymphoepithelial lesion. That's lymphocyte attacking the epithelium. Okay, that actually itself may be transformed into a high-grade lymphoma, in this case into a diffuse large B-cell lymphoma, or a diffuse large B-cell lymphoma may arise de novo without any preceding kind of lesion. Either way, it is the second most common type of lymphomas in the GI, known as a diffuse large B-cell lymphoma. EBV plays actually a role in gastric lymphoproliferative disorders. Gastric carcinoid, this is the tumor that we have talked about, and we talked about it, in the course of autoimmune gastritis. Once you have, taken care of the acid-producing cells, the parietal cells, acid is lost. What happened to the gastric? Starts to hike up, and the cells that produce start to proliferate. So there will be endocrine cell hyperplasia. If this continues unabated and corrected, the end result is going to be that this hyperplasia will turn into a tumor, in this case, carcinoid. Carcinoid is a word used actually to in Arabic, we call it tasghir. التصغير in this case for the Arab speakers is for what purpose? التصغير لل. So what's the carcinoid in Arabic? Suraytan, right? Saratan, suraytan. So why are you actually making it small? التصغير لل. None of you have any idea about that, do you? للتحقير. To actually say it's insignificant, even though it is supposedly a smaller version, more differentiated tumor, better prognosis, but some of it are actually highly, aggressive tumor that actually may kill the patient. One of our faculty, the spouse of one of our faculty, I will never say his name, actually, unfortunately died as a result of a carcinoid of the GI. Okay, so obviously not all the tumors read the book, and some of them are pretty aggressive. So the grading, that you do for the carcinoid are going to be assessing the mitotic count. You have to count how many mitoses are per high-powered field, and then you can give actually the grade of that specific tumor. We did talk about actually its relationship to the autoimmune gastritis, so it may result from this, or it may actually again arise de novo. Now, either way, it's going to actually be a very well circumscribed kind of tumor, smaller tumor, arising in the submucosal area, and it will not arise in the mucosa itself. So when you do scoping, you're going to be seeing probably a raised area in the mucosa, a bump in the mucosa. Okay, if you touch it, it will feel like a nodule. If you are shrewd enough, you're going to take a biopsy of it. If you do the biopsy and you look under the microscope, you will see this, what looks like a tumor that is, well circumscribed. You can tell that it's almost cut with a cookie cutter, right? When you go on higher power, you will see that the chromatin is, varies between, fine and coarse chromatin, a pattern known as salt and pepper chromatin, which is what is known to be characteristic for carcinoid tumor. Okay, you look at the cells, and the cells all look the same, uniform kind of cell. Whenever you see this kind of organization, you know that you're talking about a low-grade tumor. What is the malignant counterpart of a carcinoid tumor? Small cell or large cell neuroendocrine carcinomas. So neuroendocrine carcinomas, okay? What are the features of neuroendocrine carcinomas? Do you guys remember this from the lung? I'm not going to bother you with that. You can do it on your own. Okay. Now, very important, actually, a phenomenon that happened with carcinoid. A lot of carcinoid are hormonally active. And because of the hormones they secrete, the patient may have what is known as the carcinoid syndrome. Now, this may be the case, for example, with lung carcinoids or with carcinoids arising in other areas, in the body. But when it comes to GI carcinoid, there is what is known as the first pass effect, because all those hormonally active metabolites that the tumor is putting out are going to pass through the liver, and the liver is going to deactivate all of them. So when the liver is functional, there will be no carcinoid syndrome in those patients with GI carcinoids. Did you guys get that? Yeah. And the time when actually a patient with GI carcinoid develop carcinoid syndrome will tell you that this is very likely is actually a carcinoid that is malignant, that has metastasized to the liver and killed the liver. You see what I'm saying? So you can do what you call extrapolation in terms, of course, you need to confirm that with your imaging, but that gives you enough suspicion to know that the tumor that you are dealing with is a malignant tumor. All right, gastric mesenchymal tumors, and this is it, and then I will not bother you anymore, is actually a tumor that is not really very old. It's a tumor that has been discovered, pretty recently. I would say probably 40, 50 years, which is pretty recent. And, more recently, in 1998, we figured we were able actually to come to the point to know the original cell of the tumor. It's a mesenchymal stem cell that give rise to the interstitial cells of Cajal, which are the cells that initiate peristalsis. So this is why actually some of the clinicians and some of the scientists who discovered this tumor, they call it the pacemaker tumors of the GI, because the original tumor cells is that of the interstitial cells of Cajal, discovered by Kindblom in 1998. Another important discovery is that we have actually were able to assess a tyrosine kinase activity in those tumor cells by looking and seeing that it is c-KIT positive. Now, that's very important because we have actually medication that will go after the tyrosine kinase. Where else have you seen actually tyrosine kinase increase activity in a malignant tumor before? CML, excellent. So chronic myeloid leukemia. And in those tumors, what do you give those patients? Imatinib, absolutely. Imatinib and sustenib, and there's a long list of actually second and third generations, of those tyrosine kinase, medications. So we do have a nice thing about it. So ulcerated tumor, usually as a bump in the mucosa, because remember, it's not really a mucosal tumor. It's a tumor that is arising in the subserosal region, okay? If you take a section of this, you will see that the mucosa is fine. It is really the area underneath it that is filled with this, very bland, spindly kind of, fibers. You can take a look at that. This intersecting fibers that you see here, very bland, for the most part. And, the c-KIT mutation was discovered by Hiroto et al. In 1998 and was really a turning point when it comes to the treatment and the management of gastrointestinal stromal tumor known as GIST. So 85 to 95 of GIST have the gain of function. I am sure that you guys by now have heard about gain of function, right? What else did you hear about gain of function? Very recent, like about a year ago. I'm not asking you anything, beyond that, God forbid. No. Who said COVID? Thank you very much. COVID-19, gain of function. Does that ring a bell? I hope so. Okay, so 85 to 95% of all guests have actually a gain of function mutation. That is going to put the tyrosine kinase in hyperdrive. What does tyrosine kinase do? What does it do in CML? BCR-ABL, right? Kind of fusion gene that is going to put the cell that will have this tyrosine kinase activity and will put the cell in hyperdrive. This is exactly the same right here. Probably not with the BCR-ABL, but with the same tyrosine kinase activity that is going to make the cell actually divide like there's no tomorrow. In about 3 to 5% of the c-KIT negative patients, they will have the platelet-derived growth factor mutation. That again is going to render them, hyperproliferative tumors. And finally, gifts appear to arise from the interstitial cells of Cajal, which express the c-KIT and located in the muscularis propria. They are the pacemaker cells of the gut. Now, patients with unresectable, recurrent, or metastatic tumor often respond to imatinib, the same medication. And imatinib is an inhibitor of the tyrosine kinase activity. That's it. Thank you very much. I apologize for the long lectures, but you guys are done. Yes. Yes, here's one actually nice advice for you. Very good advice. Tomorrow is Dr. Wiles' lecture.